Hello, my name is Jim Moeller. I'm the director of the Sports Medicine Fellowship at Henry Ford Health System in Detroit, Michigan. And this is a recorded lecture on sickle cell disease and exercise. I have no financial or other conflicts of interest to disclose concerning this presentation. The goals of today's presentation are to review the genetics of sickle cell disease, review the screening and diagnostic processes, review the basics of sickle cell disease, understand the effects of the disease on exercise, and understand the effects of exercise on the disease itself. Sickle cell disease is the most common inherited illness. It is an autosomal recessive disease and most commonly seen in non-Hispanic blacks. The prevalence in the United States is 100,000, with 1 in 325 live births of African Americans having sickle cell disease. 1 in 13 African Americans in the United States are felt to be carriers. The life expectancy of someone with sickle cell disease is 42 years in a male and 48 years in a female. Sickle cell disease occurs when valine replaces glutamic acid in the 6th position of the beta-globin chain in a hemoglobin molecule. It's actually a change of adenine to thymine in a single codon, which creates the responsible mutation. When present, it leads to the formation of hemoglobin SS, which denotes sickle cell disease. In the above diagram, you see a hemoglobin molecule with 2 alpha chains and 2 beta chains, each surrounding a central heme unit which contains iron. Each molecule can bind 4 molecules of oxygen. Sickle cell disease is most common in sub-Saharan Africa. 90% of the cases worldwide are in Nigeria, India, and the Democratic Republic of Congo. 300,000 infants are born with sickle cell disease annually, and this number is expected to rise. When you consider prevalence in the United States, New York, Florida, Texas, California, and Georgia are the states with the highest prevalence. And these 5 states account for 43% of the sickle cell disease cases in the United States. Patients who have sickle cell disease are at risk for complications due to changes in the shape and elasticity of red blood cells. When deoxygenated, the hemoglobin SS polymerizes into long tube-like fibrils, which results in an elongated, rigid, or sickled cell. The alteration of shape and lack of flexibility makes it more difficult for the cells to traverse through small blood vessels, particularly the capillaries. The sickled cells are more adhesive to endothelial cells and can activate endothelial cells, leading to greater vaso-occlusion. The odd shape also makes it difficult for oxygen to bind. The valine substitution, which we discussed earlier, creates a hydrophobic interaction between cells, so cells tend to stick together, again increasing the vaso-occlusion. Several triggers for the sickling process are listed here. When the condition leading to sickling is reversed, the cells may return to normal shape and function, but some are irreversibly changed. Those are hemolyzed intravascularly or removed in the sinusoidal RES networks. This leads to anemia, which can have a protective effect in vaso-occlusive crises by helping reduce the blood viscosity and deoxygenation, thereby reducing the likelihood of polymerization. Sickle crisis occurs when vaso-occlusion leads to reduced blood flow and reduced oxygen delivery to various tissues. This can create painful ischemia, infarction, and reduced organ function. Commonly affected organs include the liver, kidneys, lungs, and brain. Avascular necrosis of bone can cause severe musculoskeletal pain. Newborn screening for hemoglobinopathies, including sickle cell disease, sickle trait, and sickle beta thalassemia, is a Level A recommendation from the Health Resources and Services Administration Discretionary Advisory Committee on Heritable Disorders in Newborns and Children, and this recommendation is echoed by the U.S. Preventive Service Task Force. The mission of the Advisory Committee on Heritable Disorders in Newborns and Children is to reduce morbidity and mortality in newborns and children who have or are at risk for heritable disorders. The committee recommends that every newborn screening program include a uniform screening panel that screens for 35 core disorders and 26 secondary disorders. Hemoglobinopathies are considered a core disorder. In the United States, screening is mandated. Most state-based screening programs utilize thin-layer isoelectric focusing or high-performance liquid chromatography techniques performed on capillary blood collected from heel stick and absorbed onto filter paper. The sensitivity and specificity of these tests approach 100%, but it's not perfect, so later workup may be required to make a diagnosis. Symptoms in early childhood may include jaundice, fatigue, painful swelling of the hands or feet, and kids may come in frank pain crisis. Moderate anemia is often seen, and the diagnosis is confirmed by peripheral blood smear, which shows sickled cells. Hemoglobin electrophoresis can also be beneficial in making the diagnosis. In the illustration on the right, a person with hemoglobin A, which is normal hemoglobin, would have a solid band only in the hemoglobin A area. A patient with sickle cell trait would be divided between hemoglobin A and hemoglobin C, as you see in the center illustration. And a patient with sickle cell disease would have hemoglobin SS, so both strands would be in the hemoglobin S region. Peripheral smear may also show basophilic remnants of cell nuclei. Remember that red cells have no nucleus. These abnormal cells are typically cleared by the spleen, and their presence is consistent with splenic autoinfarction, which is seen in sickle cell disease. These are called Howell-Jolly bodies, named after William Henry Howell, who pioneered the use of heparin as an anticoagulant, and Justin Mary Jolly, who produced the earliest micro-movies showing cell mitosis. Severe anemia can develop and can be life-threatening. Aplastic crisis is usually caused by a parvovirus B19 infection. This is the same virus that causes fifth disease or slap cheek syndrome. Parvovirus B19 is a very common infection, causing fever, joint pain, flu-like symptoms, and runny nose. But in sickle cell disease, it can cause the bone marrow to stop producing new red cells for a while, leading to severe anemia. Splenic sequestration crisis happens when red blood cells get trapped in the spleen, making it quickly grow larger than normal. With red blood cells trapped in the spleen, fewer are available to circulate in the blood, and this can lead to severe anemia. A large spleen may also cause pain in the left side of the abdomen. It may be precipitated by parvovirus B19 infection, acute chest syndrome, or high-altitude exposure. The CT scan, which should be coming up in just a moment, shows an enlarged spleen which is compressing the kidney. Aplastic crisis and splenic sequestration crisis most commonly occur in newborns and children who have sickle cell disease. Adults who have sickle cell disease may also experience episodes of severe anemia, but these usually have other causes. Complications of sickle cell disease are numerous. Acute pain crisis is also known as sickle cell or vaso-occlusive crisis. This can occur without warning when sickle cells block blood flow and decrease oxygen delivery. People describe this as sharp, intense, stabbing or throbbing pain. Pain can strike almost anywhere in the body and in more than one spot at a time. Common areas affected by pain include the abdomen, chest, lower back, and arms and legs. A crisis can be brought on by high altitudes, dehydration, illness, stress, or temperature changes. Often a person does not know what triggers or causes the crisis. The U.S. Food and Drug Administration approved new medicine in 2019 to help reduce the number of pain crises experienced by people who have sickle cell disease, and we'll talk about medications in a moment. In acute chest syndrome, sickling in blood vessels of the lungs can deprive a person's lungs of oxygen. When this happens, areas of lung tissue are damaged and cannot exchange oxygen properly. This condition is very serious and should be treated right away at a hospital. Acute chest syndrome often starts a few days after a painful crisis begins. A lung infection may accompany acute chest syndrome. The most common site of eye damage is the retina. The main cause of trouble is blood vessels that overgrow, get blocked, or bleed. Detachment of the retina may also occur. Heart problems such as ischemic heart disease and pulmonary hypertension are not uncommon in patients with sickle cell disease. Infections are common. The spleen is important for protection against certain kinds of infections, and people who have sickle cell disease and damaged spleens are at risk for certain kinds of infections, including chlamydia, Haemophilus influenza type B, salmonella, and staphylococcus. And we'll talk more about this in a moment. Sickling in the hips, and less commonly in the shoulder joints, knees, and ankles, can decrease oxygen flow and result in a condition called avascular or aseptic necrosis, which severely damages the joints. Symptoms include pain and problems with walking and joint movement. A person may need pain medications or surgery, and joint replacement is sometimes necessary if the symptoms persist. Let's talk more about the infections, which I mentioned a moment ago. Patients with sickle cell disease are at increased risk for salmonella infection, but they're also at risk for infection from encapsulated organisms due to a poorly functioning spleen. Gram-negative organisms include E. coli, Neisseria meningitidis, Klebsiella, and Haemophilus influenza type B. The gram-positive organisms include Streptococcus strains Staphylococcus and Bacillus. Due to the increased risk of infection, it is recommended that patients with sickle cell disease receive various immunizations to protect against infection from encapsulated organisms and other organisms as well. There are several goals in the treatment of sickle cell disease: reducing episodes of pain crisis, reducing the risk of complications, which we listed out before, reducing anemia, and limiting infections are all goals of treatment. As I mentioned, the FDA has recently approved the use of certain medications to reduce the likelihood of pain crisis. Hydroxyurea daily reduces the frequency of pain crises and might reduce the need for blood transfusions and hospitalizations. It can, however, increase the risk of infections and should not be taken in pregnancy. L-glutamine oral powder has been approved recently by the FDA to try to help reduce the frequency of pain crises. Crizanlizumab has also recently been approved by the FDA for use in patients 16 years of age and older for treatment of sickle cell anemia. It's given IV and helps reduce the frequency of pain crises by preventing the cells from sticking together. Voxelotor has recently been approved by the FDA. This is an oral drug to be used in patients 12 years of age and older to improve anemia. Certainly, pain medications are commonly used to reduce the discomfort from sickle cell pain crisis. I want to take a minute to discuss the use of penicillin to limit infections. In children who have sickle cell disease, taking penicillin 2 times a day has been shown to reduce the chance of having a severe infection caused by the pneumococcus bacteria. Many doctors will stop prescribing penicillin after a child has reached age 5, though some prefer to continue this antibiotic throughout life, particularly if a person has hemoglobin SS or hemoglobin S beta thalassemia, since people who have sickle cell disease are still at risk. All people who have had surgical removal of the spleen or a past infection with pneumococcus should keep taking penicillin throughout life. Transfusions may be necessary to treat severe anemia or to prevent certain sickle cell disease complications. Aside from the severe anemia, acute transfusions can be used to treat acute stroke, acute chest crisis, and multi-organ failure. Bone marrow transplant is the only cure for sickle cell disease. Most transplants are currently performed in children who have had complications such as strokes, acute chest crisis, and recurring pain crises. Blood and bone marrow transplants are riskier in adults than they are in children. These transplants are successful in about 85% of cases involving children when the donor is related and HLA matched. Even with this high success rate, transplants still have risks. Complications can include severe infections, seizures, and other clinical problems. Approximately 5% of people who receive such transplants have died from graft versus host disease. So when we talk about sickle cell disease and exercise, the first question we have to ask is it safe for patients with sickle cell disease to exercise at high intensities? And here's a study out of France, which was published in Medicine and Science and Sports and Exercise in 2019, which tries to answer that question. The researchers looked at patients with sickle cell disease, both male and female, and the subjects performed a cycle ergometer exercise test. Women started at 20 watts of power and increased every 2 minutes by increments of 10 watts. Men started at 30 watts of power and increased every 2 minutes by 15 watts until they reached a blood lactate level of 4 millimoles per liter or greater. They were monitored throughout the exercise session, and here's what was found. Both men and women had a very low work rate at the time they hit LT1. LT1, or lactate threshold 1, is the point at which the blood lactate starts to suddenly move up at a higher rate. The good news is that at LT1 they did not show any significant oxygen desaturation in the blood, and they also maintained good oxygen saturation throughout the exercise session. If you look at the different increments alone, you can see that heart rate, systolic blood pressure, and lactate levels all increased as the increment of work increased, which one would suspect. The good news again is that there was no significant oxygen desaturation at any point during this exercise session. Now, about 3/4 of these people went into a second portion of the study where they went into a more endurance style exercise at roughly 2.5 millimoles of lactate. So it was a moderate amount of work for them. And each exercise session lasted 45 minutes, had a 5-minute warm-up, 30-minute of constant cycling, a 5-minute cool down, and 5 minutes of stretching. And what was found here was that even with the much longer duration than the baseline test, both men and women were able to perform a sustained workout above their LT1 power outputs and exercise at elevated heart rates without oxygen desaturation. The conclusion, therefore, was that patients with sickle cell disease can exercise with a tailored endurance exercise program without significant risk of oxygen desaturation. Here is a German study, also published in 2019 in Scientific Reports, which looked at the effect of acute exercise on red blood cell deformability in patients with sickle cell disease. This study used a younger population than the prior study, but also used an incremental workload exercise challenge on a cycle ergometer. Red blood cell deformability was measured by a laser diffraction ectocytometer. And from what we know about sickle cell disease and what we've discussed already is we would expect the patients with sickle cell disease, which were compared to age-matched controls, would show less deformability of their red blood cells than the patients who have normal hemoglobin. And indeed, this was the case, as you can see from the graph here. The gray line are patients with sickle cell disease, and the black line are patients with normal hemoglobin, and you can see that the patients with normal hemoglobin have much more deformable red blood cells, which again allows them to change shape as they go through capillaries. What's interesting is that the red blood cell deformability did not change due to exercise. And this was both in the sickle cell disease group and in the control group. This is more good news. So not only do patients with sickle cell disease show that they can exercise without desaturating their blood, but it also shows that the exercise does not change. Here's a study published out of France in The Lancet Hematology in 2018, which investigated whether a patient-adapted training program of moderate endurance exercise on a stationary bike could be safe and beneficial for patients with sickle cell disease. Study subjects were randomized either into a training group, which performed 3 45-minute exercise sessions per week for 8 weeks. The primary outcome was the difference in power output at a blood lactate concentration of 4 millimoles per liter, which is usually the maximal allowed blood lactate amount in these tests, between baseline at the end of an 8-week training program. They also studied the work output at the LT1. The pink bar represents the untrained patients, and the blue bar represents the trained patients. In the graph on the left, you can see a 12% relative improvement in workload in the exercise group at 4 millimoles per liter blood lactate compared to a 3% relative improvement in the control group. This difference was even bigger at the first lactate threshold, which you see in the graph on the right. Muscle biopsies were performed, and this showed significant increase in capillary density after training. I apologize that I didn't take out the prior graph completely, but we're looking at the center portion where you see a statistically significant change in capillary density with a p-value of 0.003. Other positive findings in the exercise group included blood lactate concentrations at a given power output during the cardiopulmonary exercise testing decreased in the training group but was unchanged in the control group. Another interesting finding was that no adverse events requiring hospital admission occurred in the training group, whereas 5 occurred in the control group. There were 4 vaso-occlusive crises and 1 viral infection with isolated chest pain. Therefore, moderate intensity endurance exercise training seems to be safe for adults with sickle cell disease without severe chronic complications and significantly improve functional capacity, especially for exercise levels close to those needed for activities of daily living. The findings of this particular report support consideration of endurance exercise training as a novel therapeutic strategy for patients with sickle cell disease. Let's look at another study out of France, this one published in the journal Blood in 2019. Again, cycle ergometer testing was performed on patients with sickle cell disease, and patients were randomized either into a moderate intensity endurance training program or just maintaining a normal lifestyle. Cardiopulmonary parameters were blood lactate was measured, and muscle biopsies were performed before training and after completion of the 8-week training protocol in both the study and control subjects. Patients in the trained group showed increased capillary networks on muscle biopsy, although the morphological characteristics of the capillaries did not change. When tested at LT1, it was noted that power output was significantly increased in the training group, as was oxygen uptake. Tissue saturation was improved, but this did not reach statistical significance. When tested at a particular power output, which was 40 watts for women and 60 watts for men, lactate levels were decreased in the training group, as was the rate of perceived exertion. This study demonstrates that a moderate intensity endurance exercise training program over 8 weeks improves skeletal muscle microvasculature and partly reverses the microvascular deficits previously observed in sickle cell disease patients. Other things to consider: the presence of hemoglobin SS is protective against malaria. As we discussed, bone marrow transplant from a sibling may lead to good results. We have not talked about sickle cell trait. Remember that sickle cell disease is an autosomal recessive condition. Therefore, if a mother and father are both carriers for sickle cell disease, in other words, they both have sickle cell trait, there is a 25% chance their offspring will have normal hemoglobin. There is a 25% chance their offspring will have sickle cell disease, and a 50% chance they will have sickle cell trait. Patients with sickle cell trait often go through life without symptoms. However, in certain situations, they may still have sickling issues. Extreme hypoxia, exercise in the heat leading to heat stroke, and severe dehydration can all lead to sickling in patients with sickle cell trait. There have been deaths from sport participation associated with sickle cell trait, and due to this, the NCAA passed legislation requiring that the sickle cell trait status of all athletes be documented, either from previous testing, repeated testing if the status was unknown, or a waiver of liability be signed by the athlete if they decide to forego testing. In addition to screening for sickle cell trait status, the NCAA required education for athletes, including counseling on the risks and implications of sickle cell trait and guidelines for conditioning. The NCAA did not specify how the education was delivered, but provided fact sheets for both student athletes and coaches to assist with the education. Legislation went into effect in August of 2010 at the Division I level, in August of 2012 at the Division II level, and August of 2014 at the Division III level. The question is, did the legislation help reduce death from sickle cell trait? A study was recently published in Sports Health looking at this specific question. A database of NCAA athlete deaths from 2000 to 2019 was reviewed for death associated with sickle cell trait. Comparisons were made regarding death associated with sickle cell trait in the decade prior to legislation with the decade following legislation. And what I show here is only the NCAA Division I football data. Prior to legislation, there were 9 deaths in that time frame associated with sickle cell trait, all in football and all in African American males. When you consider all football players, this came out to 1 death per 28,145 athlete years prior to legislation. If you consider just the African American football players over the study period, it would equate to 1 death per 12,519 athlete years. After legislation was passed, there was 1 death associated with sickle cell trait noted in NCAA Division I football. Again, this was an African American male. When you consider all football players during that time frame, that would equate to 1 death per. This equated to a statistically significant decrease in death associated with sickle cell trait. The p-value that you see on the graph is incorrect. It should read 0.022. So again, it's 0.022, which is a statistically significant change. This equated to an 89% reduction in death associated with sickle cell trait. There were 2 other deaths associated with sickle cell trait during the time frame of this study. One was in a Division II football player, which occurred prior to the institution of legislation at the Division II level, and the other was in a Division I track and field athlete, which occurred after the institution of legislation at the Division I level. Both of these athletes were African American males. None of the deaths occurred during competition, most either during conditioning or practice. It's clear from this information that the incidence of death associated with sickle cell trait in Division I football athletes has decreased significantly since legislation was enacted. It also shows that cases of death associated with sickle cell trait are rare outside of football. And presently, we've only seen this in African American males. What we don't know is, has this improvement been due to our knowledge of the sickle? We don't know the sickle trait status of all athletes. Athletes may sign a waiver if they decide not to be sickle tested, even though we offer testing to all of those who have an unknown status. I would argue that regardless of whether it's due to knowledge of the sickle trait status or the education, it's just a good thing that the legislation has led to a decreased incidence of death associated with sickle trait. Patients with sickle cell anemia should avoid certain activities. Scuba diving and mountain climbing, for example, are contraindicated in patients with sickle cell disease. They should also take special care to avoid overheating, overcooling, dehydration, and overexertion. Many sports are difficult due to reduced exercise capacity. Despite the reduced exercise capacity for athletes with sickle cell disease, those with sickle trait often participate in high-level athletics. When considering all sports and all divisions of the NCAA, it is estimated that 3,500 athletes participate with sickle cell trait each year, including 840 in football. Despite the potential difficulties of competing at a high level, there are several athletes with sickle cell disease who have excelled in sport. Billy Garrett is a G League NBA athlete and the only publicly known NBAer with sickle cell disease. Santonio Holmes and Tiki Barber had very successful NFL careers in the face of sickle cell disease. I hope this information has been helpful to you, and I thank you for your attention on today's lecture.